We're going to start today with an endoscopy research update for the everyday endoscopist. I have Sander Smeets, Lien de Bels, and Steven Heitman here with me. And I'm going to immediately give the word to Sander Smeets.
So what is the relevance of a score, or that kind of score? Like, it's for early gastric cancer. So gastric cancer is the 5th most common cancer worldwide and the 3rd cause of cancer-related deaths. For early gastric neoplasms with low risk of lymph node metastases, ESD is the first line in treatment. It has a similar long-term outcome as a radical gastrectomy with lymphadenectomy, with a low risk of lymph node metastases, with a lower procedural time and risk of adverse events compared to a gastrectomy. It's been discussed yesterday in the upper GI session. Patients are selected for ESD depending on the macroscopic aspect of the lesion, of the gastric lesion, and also the histology upon biopsy. We also know that 15 to 20% of those ESDs, however selected, are considered non-curative after histological evaluation of the specimen. So actually we do need a score to estimate the risk of local parietal recurrence and lymph node metastases, to compare it with surgical risk in those patients. So the authors of this article, they wanted to validate the EQRA system, the EQRA score, in the Western population. So it assesses the risk factors for lymph node metastases and gastric cancer mortality after non-curative resection. The EQRA score was created in Japan and validated in an Asian population. So the question was, is it relevant for the Western world? This is the EQRA system, probably known to most of you. For 5 risk factors, you get points for every risk factor. And then you add those up, and then you got an estimation in percentages of lymph node metastases. So the authors, they compiled, or they analyzed the statistics on their population, and they decided that the sensitivity of submucosal invasion was actually higher when we used a different cutoff. So the Asian population, the cutoff was half, 0.5 millimeters. They saw that the sensitivity was higher than when they used 1 millimeter. But then you see that the EQRA actually, the risk is different. So for the Japanese population, the low risk, so 0 to 1, they actually have a 2 to 2.5% risk of lymph node metastases. The authors found in the Western population 0. So this was the first article that I found. The second one is a bit more lighter literature. Was the role of colonoscopy in young patients in rectal bleeding. So we do know that red blood loss is a common occurrence in common anorectal disorders, hemorrhoids, fissures, and so on. But it can also be a symptom of occult colorectal carcinoma. So what do we do then? So if you're above 50 years, it's quite straightforward to do a colonoscopy. And then we see that in the period between 2013 and 2017, the incidence of colorectal carcinoma decreased with 1% per year, and also the overall mortality decreases. But what we also noticed that in the population younger than 50 years, so there is no consensus. Do we do a colonoscopy? Do we do a left colonoscopy? Do we do some other investigations? But we see in this population that in the period between 2012 and 2016, the colorectal carcinoma incidence actually increased by 2% per year, and the mortality increased with 1% per year.
And the 4th one is also an incomplete resection of a previously identified lesion. And we see that in both the UK study and in the Spain study that actually missed lesions are the main cause of post-colonoscopy colorectal cancer. So I think there is still some work to do, and that we need to improve the quality of the screening colonoscopies that we do. So I hope with GIEQs that we are making a step in that direction.